So good morning, respected teachers and my dear friends. So welcome to today's journal club. So the first article will be presented by me, Dr. Lakshmi, who is a final year resident, and my moderator is Dr. Sylaja ma'am. So the article is titled MRI Predictors of Cognitive Function After Lacunar Infarction by Hassani et al. Got published in Stroke Journal in May 2025. So post-stroke cognitive impairment refers to any cognitive deficit that manifests following a stroke, regardless of the underlying stroke cause. Domains affected include deficits in memory, attention, executive function, language, visuospatial abilities, as well as other higher order cognitive domains. And the most severe form of the spectrum is post-stroke dementia. So up to 60% of stroke survivors develop post-stroke cognitive impairment with the highest rates soon after stroke. And about 44% have impaired global cognition within 2 to 6 months after stroke. Post-stroke cognitive impairment and dementia are common after intracranial hemorrhage, especially lobar ICH. And at 1 year after ICH, 14.2% develop new onset dementia, with 23.4% for lobar ICH and 9.2% for non-lobar ICH. So 1 year after stroke, the post-stroke cognitive impairment was present in approximately 8.2% of patients with NHSS score of less than 3 and 34.4% with NHSS more than 10. So now coming to the pathophysiology of post-stroke dementia. So this image represents the conceptual framework for the factors contributing to the pathophysiology of post-stroke cognitive impairment, which include genetic susceptibility, cerebral reserve, as well as the pre-existing brain pathology, which include Alzheimer's disease related dementias, small vessel disease, the blood-brain permeability parameters. So this, along with the lifetime environmental exposures, vascular risk, and the socio-demographic factors, in fact, determine the post-stroke cognitive and functional outcome. So this image represents the small vessel disease effects on whole brain. So after an acute infarct, so there will be interstitial fluid increase that produce subtle change in the normal white matter, leading to the white matter hyperintensity formation. As time progresses, the white matter hyperintensity progresses, leading to secondary cortical thinning, and then the Valerian degeneration sets in, which cause further white matter hyperintensities, lacunes, microbleeds, as well as secondary cortical thinning. Yes. So there is a close relationship between the white matter hyperintensity and the presence of cortical microbleeds. So this image represents the white matter hyperintensity and how it progress over time. So any incident white matter hyperintensity, in this image, this is represented as white, and the normal appearing white matter is represented as orange. So the incident white matter hyperintensity on follow-up MRI can either regress because of atrophy or because of recovery, or it can remain stable, or it can expand, or it can be associated with a lacune or cavitation. So this systematic review on the predictors of post-stroke cognitive impairment using acute structural MRI neuroimaging found associations between the cognitive outcome, presence of cerebral atrophy, presence of microbleed, and the increasing severity of white matter hyperintensities. And this is another systematic review on the biological and imaging predictors of cognitive impairment. And The most consistent predictors of cognitive impairment after stroke were global atrophy and the medial temporal lobe atrophy. So this is another meta-analysis on risk factors for cognitive impairment and dementia after stroke. So they conducted the study on the baseline cognitive impairment, and they found that the patients with diabetes, presence of or the history of atrial fibrillation, the presence of moderate or severe white matter hyperintensity and white matter hyperintensity severity were associated with post-stroke cognitive impairment and stroke severity and dementia. They also found that low educational status, the previous stroke, left hemispheric stroke, the presence of 3 or more lacunes, brain atrophy, and low baseline functional status were independently associated with the development of post-stroke cognitive impairment. So with this background, our study aimed to investigate association between cognitive function in lacunar infarction patients and 6 specific MRI measures, either individually or in combination. So this include total lacune count, the largest lacune size, ventricular size, cerebral atrophy, lacune location, and white matter disease extent. So this is a retrospective analysis of a prospective cohort from the American Stroke Association Berger Foundation Small Vessel Study, which included 200 participants within 2 years of an acute lacunar infarct between December 2007 and August 2012 at 4th North Carolina sites. Inclusion criteria include clinical diagnosis of a classical lacunar syndrome, either a pure motor stroke, pure sensory motor stroke, clumsy hand dysarthria, or ataxic hemiparesis, with an MRI confirmation of stroke reviewed by a neuroradiologist, a lacune definition as a lesion more than or equal to 2 millimeter in the brainstem, basal ganglia, or internal capsule, compatible with single perforator small artery occlusion and the clinical symptoms. Exclusion criteria include more than or equal to 50% stenosis of the ipsilateral carotid artery, atrial fibrillation, or other high-risk embolic source like mechanical prosthetic heart valve, the recent MI, dilated cardiomyopathy with ejection fraction of less than 30%, atrial myxoma, infective endocarditis, left ventricular thrombus, akinetic left ventricular segment. Patients with no brain MRI or missing cognitive assessment, and for sensitivity analysis, patients on acetylcholinesterase inhibitors or NMDA receptor antagonists at the time of stroke were excluded, presumed pre-existing dementia. So the final cohort, so out of the 200 initial participants, 3 were excluded for lack of acute stroke on MRI. MRI on acute stroke, and 63 for missing MRI or cognitive data. And this included 134 patients in the final cohort. So MRI parameters assessed include white matter hyperintensity, which is defined as the focal signal hyperintensities on T2 weighted scan, not seen or feigned on T1, which is graded semi-quantitatively using the cardiovascular health study, that is CHS score, which was graded 1 to 8 for extent. And the ventricular enlargement also was graded using the CHS score 0 to 8. Atrophy was also assessed using the CHS score, and they looked into the sulcal widening, and this was also similarly graded. They've given only this image in the supplementary material. Reference was not given. When I searched it, so it's a visual analog scale is what they have given. Visual analog, no, it's a visual analog scale. So the MRI measures, in addition to white matter hyperintensity, cerebral atrophy and ventricular size included lacune size, which was categorized as small, that is 3 to 10 millimeter, or large, which is more than 1 centimeter. Lacune location, which is classified as supratentorial, infratentorial, or both. And the patients lacking GRE, so only 21 patients had GRE imaging. So hence the GRE findings were not included in the final analysis. Yes, ma'am. So microbleeds were. So the outcomes that were analyzed include global cognition and the executive function. So in the global cognition, it is assessed by the total score of the short form Montreal Cognitive Assessment. And the short form MOCA includes orientation, immediate and delayed recall, and a phonemic fluency task. And with a maximum score of 16 points, with a cutoff less than 12 indicates cognitive impairment, and less than 9 indicates dementia. So executive function was assessed by the time to complete trail making test part B. And this trail making test part B measured executive function and mental flexibility. So the patient data was analyzed using were summarized as either continuous variables or categorical variables. Continuous variables were presented as mean or median, categorical as percentage. The short form MOCA analyzed both as dichotomized, that is, normal is more than 12 and abnormal is less than 12, and non-dichotomized approach. So this dual approach was used to align with the methodologies from the previous studies. And the linear regression models were used to assess association between 6 radiographic MRI measures and continuous cognitive outcome. So the MRI, the radiographic measures included size of index lacunar infarction, the number of stroke, index and the non-index radiographic lacunes, cerebral atrophy, extent of white matter disease, ventricular size, location of acute lacunar infarct, and the non-index radiographic strokes. So least absolute shrinkage and selection operator, that is lasso regression model, was used for variable selection. This is a linear regression model that incorporates both regularization and feature selection to improve prediction accuracy and model interpretability, especially in datasets with many variables and high multi-collinearity. So the statistical software used was SAS 9.4, and the p-value was taken significant when it is less than 0.05. And the study reported in accordance with the STROBE guidelines. Now coming to the results. So the patient demographic, clinical, and neuroimaging characteristics include total of 134 patients were studied, and in that the average age of onset of stroke was 63.3, and with the average year of 12.2 years of education. And 50% of patients were female. And the characteristics were, this short form Montreal Cognitive Assessment was taken by 134, that is total patients, 134 patients, and the median score was 12.1, and 39 participants, that is 29.1% scored less than 12, indicating cognitive impairment. And the trail making test B, so the total number of participants were 100, and the mean time was 131 seconds. Median time was 131 seconds. So short form MOCA included the following tests, that is orientation, immediate, delayed recall, and phonemic fluency. So the maximum score is 16 points. So the cognitive assessments were completed at a mean of 76.5 days from the onset of index lacunar infarct. So after adjusting for covariates, none of the MRI measures were significantly associated with the short form MOCA score. Yes, ma'am. Only 100 participants completed. Yes, ma'am. Stroke severity was NHSS. Yes. So after adjusting for the covariates, none of the MRI measures were significantly associated with the short form OCA scores as a continuous variable. So the size of the stroke, the number of strokes, atrophy, ventricular size, then the lesion location, whether there is that is located in supratentorial, infratentorial, or both, and the white matter disease extent was studied. So none of these measures were significantly associated with the short form OCA score as continuous variable. And the univariate analysis, ma'am, that is based on that visual analog score. Let's see. Severity and only the like the volume, that is the extent they have mentioned, ma'am. Pasika. Significance of periventricular white matter and the subcortical. The subcortical. So here, here the white matter areas are not compared. Only the only looked at the numbers. Like CHS score, which is no, ma'am. In the supplementary material also they have given only this much. That is in the. It is the American Heart Association visual analog scale. Visual analog scale is what they have mentioned. Yes. Yes. Two. Severity is 1 is less severe and 8 is more severe. Further, like 1 to 4 is like 1 to 4, and then 5 to 8 is more severe. Yes. So univariate analysis also showed no significant association between the MRI findings and the dichotomized short form MoCA score. So lasso logistic regression identified total number of strokes as the only MRI predictor for the dichotomized short form MoCA. However, after adjustment, this association was also not statistically significant. So univariate analysis showed that cerebral atrophy, ventricular size, and the extent of white matter disease was statistically, that is significantly associated with the time to complete the trail making test part B. But in the lasso regression selected the model, only white matter disease extent was independently associated with the trail making test B time. So coming to discussion, so the extent of white matter disease is independently associated with executive function as measured by the time taken for completion of trail making test part 2 after lacunar infarction, even after adjusting for other MRI measures and clinical variables. Other MRI measures, which include cerebral atrophy, ventricular size, number of lacunes, lacune size, and location, were not independently associated with executive function after adjustment. White matter disease reflects the chronic microvascular and neurodegenerative changes and is a strong predictor of long-term cognitive and functional outcome post-lacunar infarction. So recent studies suggest white matter disease may affect multiple cognitive domains, not just the executive function. So this study on a general population on the white matter changes in healthy elderly persons showed that processing speed, executive function, and attention are among the most cognitive domains conventionally affected by the white matter disease. So this study on the strategic white matter hyperintensity location for cognitive impairment on 3,525 memory clinic patients showed that white matter hyperintensity in left and right anterior thalamic radiations, forceps major, and left inferior fronto-occipital fasciculus were significantly related to domain-specific impairment independent of total white matter hyperintensity volume and atrophy. So disruption of specific white matter tract is a key mechanism through which subcortical vascular damage impairs cognition. Cerebral atrophy and ventricular enlargement were associated with executive dysfunction in univariate analysis, but not after adjustment for other variables. Ventricular enlargement is a known marker of cognitive decline in Alzheimer's disease, but it is less studied in post-stroke population. So lacune locations, that is supratentorial versus infratentorial, was not associated with cognitive outcome, possibly due to a limited sample size and cognitive domains assessed in our study. So this, that is leukoariosis and disability study, that is a LADIS study, studied 387 subjects who were evaluated with repeat MRI and neuropsychological assessment. They found that the number of new lacunes were related to subtle decrease in the compound scores for the executive function and speed and the motor control, but not for memory or global cognitive function. So in this LADIS study, they have taken the white matter hyperintensities as, so they have grouped into frontal, parieto-occipital, temporal, basal ganglia, as well as the infratentorial origin. And they have found that the executive function is more affected in patients with white matter hyperintensities in the frontal than the other regions. And the cognitive impairment is common after lacunar infarction, affecting about 1/3 of patients. And the white matter disease extent on MRI at the time of stroke may help identify patients at risk for cognitive dysfunction, aiding in prognosis, follow-up planning, and the patient counseling. So there are currently no validated clinical prediction tools for post-stroke cognitive impairment, and this study supports including white matter disease in future models. So coming to the limitations of the study, so there is a lack of information about the participants' cognitive function before their lacunar infarction. So although patients with known dementia were excluded, inclusion of those with undiagnosed mild cognitive impairment or dementia, not on medication, is possible. And MRIs were obtained as a part of routine clinical care. And we have seen that the GRE sequence were not assessed. So hence the cerebral microbleeds as well as the perivascular spaces were not evaluated in the study. And it's a observational, it has a observational study design. So regression models were used to assess associations, but causality cannot be identified. And there is a potential for misclassification because some patients with an undiagnosed cognitive impairment may have been included in the study, contributing to variability in reported cognitive impairment. So the strength of the study include it has a focused population. So the study specifically examines patients with acute lacunar infarction, providing targeted insights into this important stroke subtype. And multiple MRI markers were assessed, allowing for a robust evaluation of imaging predictors. And analysis were adjusted for key clinical variables like age, sex, education, stroke severity, as well as vascular risk factors, reducing confounding bias. So Lasso, by using Lasso regression model, the accuracy is improved. And the study included a racially diverse sample because 1/3 of the participants were Black, enhancing generalizability to broader population. So the findings support the use of white matter disease extent on MRI as a predictor of executive dysfunction after lacunar infarction, which may inform the risk stratification and follow-up planning. So overall, the study adds valuable evidence regarding the role of white matter disease in post-stroke cognitive impairment after lacunar infarction. Limitations, particularly the lack of pre-stroke cognitive data and cross-sectional design, should temper interpretation. And the results highlight the need for further longitudinal and mechanistic studies to refine prediction and intervention strategies. Thank you. Yes. Yes. Paseka. Both. So modifiable as well as non-modifiable risk factors are there. So modifiable include the age of the patient, the risk factors like diabetes, hypertension, then this smoking. Other factors, age of the patient. Mm.
So good morning. Today's second journal club will be presented by me, Dr. Surabhi, and it will be chaired by Ashish sir. So this article, it is based on this article that is changing management of focal cerebral arteriopathy of childhood from 2010 to 2022, and it was published in Stroke Journal in June 2025. It is by Fullerton et al. So coming to a brief introduction, so stroke is an important cause of neurological morbidity in children, and most survivors, they have a permanent neurological deficit that affect the remainder of their life. And stroke in childhood is basically defined as stroke from 29 days of age up to 18 years of age. And the causes of childhood stroke are distinct from those in adult. So this paper which was published This paper, which was published by Fullerton et al. In 2022, shows the main etiologies behind childhood stroke. And so we can see that around so the around 36% of the childhood stroke is caused by cardioembolic etiology, and around 50% of the cause of childhood arterial stroke is caused by arteriopathy, which is mainly non-atherosclerotic. And in that, around 30% is by cervical arteriopathy, and the remaining is by cerebral arteriopathy. And the most important cause, around 31%, is by moya moya. And in around 10 up to 23% of the stroke is caused by FCA, that is unilateral focal cerebral arteriopathy. So, which is the topic of interest today, that is focal cerebral arteriopathy. So, it is the most common intracranial arteriopathy in previously healthy children, and it accounts for more than 10% of all causes of childhood acute ischemic stroke. And the median age of presentation for FCA is around 11 years. And so, basically, it is a imaging diagnosis. So we need to have an MRA or CT angiography. And so based on that, the definition of focal cerebral arteriopathy by International Pediatric Stroke Study, it is defined as a unifocal and unilateral stenosis or irregularity of the large intracranial arteries of the anterior circulation, that is the distal internal cerebral artery along with its proximal branches, that is MCA and ACA. And it is basically classified into two types, that is FCA dissection type and FCA inflammation type. And so basically the child around the age of 11 years will present with an acute ischemic stroke mainly in the anterior circulation. And we can see a lenticular territory subcortical infarction usually. And there will be foculosegmental narrowing in the distal ICA and the proximal MC and the ACA branches. And although it predominantly affects the anterior circulation, FCA inflammatory type can involve the posterior circulation also in around 25% of cases. And usually FCA inflammatory type typically runs a monophasic course with progression of the stenosis during the initial 3 to 6 months, followed by stabilization and less often normalization. And the main step. So the most will show contrast enhancement, concentric enhancement. And so the most common differentials for a have a concentric enhancement. So the main differential for a focal cerebral arteriopathy will be a unilateral moya-moya disease, which can also present in a similar way, but especially early moya-moya may be unilateral, as well as there will be absence of the basal collateral vessels. And also another DD will be a cardioembolic stroke. So how to differentiate is the FCA will usually stabilize. So the follow-up imaging is very important in case of FCA. And outcome, while FCA is considered as a monophasic disorder, recurrent events are not infrequent. So the recurrence can happen in around 3 to 25%. And usually the arteriopathy will stabilize by 12 months. And around 6 to 20% of the children who are initially diagnosed as FCAI can evolve to a progressive unilateral arteriopathy or a bilateral disease like moya-moya. And complete or near complete recovery is present only in 40% of the cases, but a majority of cases have a residual neurological deficit. Coming to the pathology of focal cerebral arteriopathy, so the hypothesized mechanism behind FCA is an inflammatory response, predominantly to a viral infection like a varicella zoster infection. And the mechanism is the virus will establish latency in the trigeminal ganglion, and then through transaxonal spread, it will involve the adventitia of the blood vessels, especially in the distal ICA and the proximal MCACA branches. And it is also common, it was also found to be associated with other infections like enterovirus, mycoplasma pneumonia, and herpes virus. And however, we have only limited evidence that FCA is an inflammatory arteriopathy. So this is an article which was published in Stroke Journal, which predicted the progression of intracranial arteriopathy in childhood stroke with vessel wall imaging. So in this study, a total number of 16 patients were included, and out of this, 10 patients had unilateral focal cerebral arteriopathy. And so in this, 9 out of the 10 patients had vessel wall imaging showing concentric enhancement. And out of this, 9 out of this 10 patients also had a progressive course. So by this study, they postulated that the patients who are having a concentric vessel wall enhancement are likely to have an inflammatory mechanism, and they're likely to progress. And this is another study which was published. It was on elevation of CSF fluid, cytokine, and chemokines. This 3-month and 6-month imaging was done. So this was another study which was published, showed the elevation of CSF biomarkers, that is cytokines and chemokines. So in this study, a total of 32 patients, 5 patients with FCA was included, and CSF study was done on them after the within 4 days of the acute ischemic stroke, and it was found that these markers IL-6, IL-8, these chemokines were significantly higher in the FCA group. So the study found a higher levels of inflammatory cytokines in CSF and in children with FCA versus children with stroke due to other etiologies. And so basically the standard treatment for FCA includes antithrombotics and supportive care, and steroids or immunomodulation is not included as a recommended guideline. So treating the patient with antithrombotics and supportive care, it would not address the presumed underlying inflammatory mechanism, and it does not prevent the FCA progression also. So this study, which was published in 2017 by Stenlin et al., uh, he actually looked into whether steroids can improve the outcome in FCA patients. So this is basically a Swiss-Australian cohort study. It is a retrospective study, and it included patients with aged 1 month to 18 years who presented with acute ischemic stroke, and from 2000 to 2014, and because of focal cerebral arteriopathy. And the primary outcome that he looked into was the presence of neurological deficit at 6 months post stroke, measured by the pediatric stroke outcome measure. And the secondary outcome included resolution of stenosis and stroke recurrence. So the study basically included 73 patients, and out of which, these 73 patients were divided into two groups. One group received the combined treatment, that is combined corticosteroid plus antithrombotic treatment, and the other group received only the antithrombotic treatment. So when the primary outcome was analyzed, it was seen that the median pediatric stroke outcome measure 6 month post stroke was 0.5 in the combined group compared with 1 in the antithrombotic group. So with the significant p-value of 0.035. So based on that, he concluded that corticosteroid treatment may provide an additional benefit over the antithrombotic treatment for improved neurological outcome in childhood stroke because of FCA. And when I searched the literature, only this. Looking into other evidence, there was not much evidence for immunotherapy in FCA cases other than this other article. This included around 2 cases of FCA and around 13 cases of varicella zoster vasculitis. From this study, they concluded that there was a weak evidence to use steroids in ischemic stroke. So coming to our current study, so based on this 2017 article by Steenlin et al., they wanted to see after this article whether there was a change in the trend of treatment of FCA. So before the 2017 article, this VIPS study was published, that is the Vascular Effects in Pediatric Stroke study, which commenced in 2010 to 2014. And also after the study, VIPS2 study was enrolled, that is from 2016 to 2022. So basically, by comparing both these studies, they wanted to know if there is a change in the treatment after the study, which was published by Stenlin et al. So the aim of the study was to compare the FCA cohorts from the two VIPS studies for the change in practice of treatment, and they hypothesized that corticosteroid treatment rates increased in the VIPS2 FCA cohort compared to VIPS1 cohort, with a corresponding improvement in the neurological outcome. So before going into that, I just want to briefly mention about the VAPS-1 study. So that actually enrolled around 355 cases of acute ischemic stroke of childhood. And basically, this study hypothesized that infection transiently increases the risk of acute ischemic stroke in children, regardless of the stroke subtype. And the conclusion was that the infection in the week prior to the stroke was reported in 18% of cases who presented with a stroke, compared to only 3% in the controls. So, infection may act as a trigger for childhood acute ischemic stroke. That was the conclusion of this VAPS study. And based on the VAPS data, several studies were published. And this study was also published based on the VAPS data, which looked into the clinical and imaging characteristic of arteriopathy subtypes. In that, from the VAPS-1 cohort, FCA cases involved total 41 cases, out of which FCA inflammatory type was 25 cases and section type was 26 cases. And from the study, they found out that a banded appearance of the M1 segment of the MCA was pathognomonic for FCAI. Coming to the present study, so VAPS-1 study was conducted in 37 international centers, and it enrolled 355 children with acute ischemic stroke, both spontaneous or iatrogenic, from 2010 to 2014. And VAPS-2 study uh, uh, involved 22 centers, mainly 21 North American and 1 Australian center, and it enrolled 205 children with acute ischemic stroke, and it was conducted from 2016 to January 2022. And both these studies had local ethics approval and obtained consent. And both included children from the age of 28 days up to 18 years of age who presented with acute ischemic stroke, defined as neurological deficit with acute onset with corresponding acute infarct in an arterial territory on the brain imaging. And unlike VAPS-1, VAPS-2 included only case with an etiology classified as arteriopathic, cardioembolic, and idiopathic, whereas VAPS-1 also included those with iatrogenic stroke, a non-arteriopathic stroke, like associated with medical etiology like cancer also. And using methods from VAPS-1, the primary stroke types were classified as definitive arteriopathy, possible arteriopathy, cardioembolic, and idiopathic. And this definitive arteriopathy was again classified as focal cerebral arteriopathy, moya, arterial dissection, and vasculitis. So coming to the definition of FCA was the same. And this possible arteriopathy cases were those patients who presented with an acute ischemic stroke who had an abnormal vascular imaging that could represent an arteriopathy or a thrombus. And the definite diagnosis of FCA required a serial imaging which showing an arteriopathy evolution, whereas this thrombus would resolve on serial imaging. So, but both these cases were taken as possible arteriopathy. And this intracranial dissection involving the anterior circulation were classified into FCA dissection type. And so basically they have used this FCA severity scoring in the study. So this was developed in the VAPS-1 cohort. So this was a scoring measure based on imaging to know the severity of the focal cerebral arteriopathy. So basically, it sums up the severity of involvement of these 5 arterial segments which are most commonly involved in the FCA. That is a supraclinoid ICA, M1 and M2 branches of MCA, and A1 and A2 branches of ACA. And for each segment, they have scored into from 0 to 4. 0 is normal, 1 is just irregularity without stenosis, 2 is less than 50% stenosis, 3 is more than 50% stenosis, and 4 is complete occlusion. And so the total score is from 1, which is mild, to 20, which is severe. And from the article which was published after the VAPS-1 study, it was shown that higher maximum FCAS corresponds to a larger infarct volume with a p-value of 0.008, which was significant. And this higher FCAS will correspond to worse outcome also. That is 1 year pediatric stroke outcome measure, higher pediatric stroke outcome measure. So coming to outcome assessment, so basically the pediatric stroke outcome measure was collected by performing neurological exams when the patients returned for their clinical care, or in those patients who did not return, it was collected through telephone. And it was a validated tool. It takes into account both the cognitive as well as the sensory motor function, and it was scored from 0 to a maximum of 10. And data analysis, the demographic, clinical imaging, and treatment characteristic for children from the two studies were separately analyzed. And for continuous variables, they've used the median and interquartile ranges. And for categorical variables, they've used the frequencies and percentages. And those treated with IV corticosteroids were compared to those that were not treated with IV corticosteroids. So from what they have analyzed is, first they have analyzed separately both the VIPS cohorts, and then those patients who received corticosteroid versus those patients who did not receive corticosteroids, they have compared. Within 4 days, they have mentioned. So coming to the demographics, so VIPS 1, total 355 patients were there, and out of which 41 cases were FCA. For the total childhood stroke, the median age was 7.2. And it was 11.6 in the VIPS 2 cohort. And definite arteriopathy cases was 127, which was 36, which was almost the same. 36% in VIPS 1 study and 37% in VIPS 2 study. And the FCA cases were 32% in VIPS 1 study and 25% in VIPS 2 study. And when we check the And when we check the FCA cohort alone, the median age was similar in both VIPS and VIPS 1 and VIPS 2, which was around 11 years. And when we check the race, it mainly involved the white population, because the study was mainly conducted in the North American and European countries. And the Asian population, there was only 4 cases of FCA in the VIPS 1 and 3 cases of FCA in VIPS 2 study. And the 32% of the patients had a history of infection in the prior 1 month in VIPS 1, and 19% of the patient had this in VIPS 2. Coming to the imaging characteristics. So in VIPS 1, the baseline imaging was MR angiogram in around 93% of the patients, and CT angiogram was performed in around 34% of the patients, and 37% of the patients underwent conventional angiography, whereas in VIPS 2, 84% of the patients underwent MR angiogram, and 19% of the patients underwent CT angiogram, and none of the patients underwent conventional angiography. And when we compare the imaging timing of the first follow-up, this VIPS 2 patients had a better follow-up. That is, a repeat imaging was performed after 5 days in VIPS 2, whereas it was performed only after 10 days in VIPS 1. And follow-up imaging within 1 week was available only for 39% of the patients in VIPS 1, whereas it was available for 53% of patients in VIPS 2. And they also had a better long-term follow-up. That is, they were followed up for around 349 days in VIPS 2, whereas they were followed only for 210 days in VIPS 1. And when we compare the imaging, the infarct volume, the baseline infarct volume baseline stroke was more severe in case of VAPS 2 cohort with an infarct volume of around 22 ml, whereas it was 14 ml in VAPS 1 cohort. And so the baseline FCAS score also was higher in VAPS 2, that is 6 in VAPS 2, and with a maximum FCAS of 9. Whereas in VAPS 1, the baseline was 4 with a maximum of 7. However, when we check the change of FCAS score on follow-up, it was only 9 in VAPS 2, whereas it was 3 in VAPS 1. That is, so, so it suggests that although the baseline severity was high, the evolution of the stroke was much lesser in the VAPS 2 cohort as compared to the VAPS 1 cohort. So coming to the treatment, so in VAPS 1 cohort, only 5% of the patients, that is 2 patients, were treated with IV corticosteroids, whereas in VAPS 2, on 18 patients, that is more than 50% of the patients were treated with IV corticosteroids. And the days at which the median days after the stroke in which they were treated was 2.5 days in VAPS 2, whereas this data was not available for the VAPS 1 cohort. And when we compare the antithrombotic treatment also, we can see a change in trend. That is, more number of patients were treated with anticoagulant when compared to antiplatelet. But in VAPS 2, around 63% of the patients were treated with antiplatelet and only 16% of the patients were treated with anticoagulant. And more number of patients underwent thrombolysis, as well as 2 patients also underwent endovascular thrombectomy in the VAPS 2 cohort. And so then they compared the, they're saying that before 2014, physician might have thought of more of a cardioembolic etiology for the stroke and more treated with. And then after this study by Stenlin et al., more people started using antiplatelet. And when they were enrolled in the VAPS 2 cohort also, they had to be treated with antiplatelet. Then they compared the IV corticosteroid group versus the no IV steroid group. So when we compare that, the baseline FCAS score in the IV corticosteroid group was higher than the no IV steroid group. That is 6 compared to 5, and maximum FCAS score was also 9 compared to 8. And however, the change in FCAS score was lesser in the IV corticosteroid group, but it was not statistically significant. And also, they compared the 1-year follow-up, recurrent stroke in 1-year follow-up, which was actually higher in the IV corticosteroid group, which was not statistically significant. And the median time to recurrence of the stroke in days was 3 days in IV corticosteroid group versus 5.5 in no IV steroid group. And the 12-month follow-up with pediatric stroke outcome measure, we could see that the score was 0.75 in the IV steroid group versus 3 to 78 days recurrence of the stroke. So the 1-year pediatric stroke outcome measure was lesser. That is a new deficit or a change in NIHS by 0.2, pediatric NIHS by 0.2. So the 1-year pediatric stroke outcome measure was lesser in the IV corticosteroid group. That was 0.75 versus 1 in no IV steroid group. So, but that was also not statistically significant. More severe disease that treated. So coming to the discussion, so we can see that the treatment of FCA with IV steroids have dramatically increased in the VIPS2 compared to VIPS1. That may be because of the modest evidence by the 2017 retrospective study by Stanley et al. And we could see that the VAPS2 FCA cases were more severe at baseline, and most severe cases might have been taken for the steroid therapy. And still, there was no significant difference in the recurrent stroke or the neurological outcome. So, this could suggest a benefit of corticosteroids. However, the statistical power was inadequate and was statistically not significant. The 2017 retrospective study did not have the level of evidence typically needed to change management because it was a retrospective study with a small sample size. And in the study, they have used heterogeneous corticosteroid dosing regimens also. But still, the physicians had adopted that corticosteroids. This may be because uh, he might have felt that the antithrombotics and supportive measures did not treat the arteriopathy, and there was an urgency to intervene during the window of opportunity before the arteriopathy progression. And in spite of the intention to treat, only 56% of the FCA cases were still treated with IV corticosteroids. That may be because of the diagnostic uncertainty, because definitive diagnosis of FCA is often, it depends on the serial imaging. And then another reason may be the safety concern of using corticosteroids for the acute stroke. And as shown in the analysis, steroids were often started days after the initial stroke. And hence, there is a lack of evidence not only of corticosteroid efficacy, but also the best timing of corticosteroid initiation. So the 2019 AHA scientific statement had identified this as an important knowledge gap, and two trials have been initiated. So one is a PASTA trial and the other is a FOCUS trial. So the PASTA trial is pediatric arteriopathy steroid aspirin. It is a randomized controlled trial which is conducted mainly in Europe and Australia and started from 2022. So this has randomized the children with FCA to corticosteroid versus no corticosteroids. And the primary outcome that they check is a change in the FCA score from baseline to 1 month. So that is an ongoing trial. And then there is a FOCUS trial, which is a comparative effectiveness trial. So this basically looks at when to initiate the corticosteroid in a case of FCA. So they have this is mainly conducted in North America and started from 2024. And so it randomizes into two arms, arm A and arm B. So arm A is to start corticosteroid as soon as FCA is suspected, and arm B is start only if there is an arteriopathy progression which is confirming the FCA diagnosis. So this is also 1 month they are checking. Baseline to 1 month they are checking. And there was also in the VIPS study, more of antiplatelet were also used. So we don't know if it was a benefit of the antiplatelet that have caused the improvement. So for the PASTA and the FOCUS trial, they specify aspirin as the antithrombotic of choice to eliminate this potential confounder. So the limitation of the study is it was a small sample size because of the rarity of the disease and the variable timing of the follow-up imaging, including the lack of follow-up within the first 7 days. That is, majority of the VIPS1 cases where minimum follow-up imaging was done, median was 10 days. And almost half of the VIPS2 cases also did not have a follow-up imaging in the first 1 week. So the peak of the FCAS might have been missed. Then there is a selection bias. That is, patients with higher baseline FCAS scores were selected for corticosteroids. And also the study did not capture data on the IV corticosteroid dose or duration or how they have tapered the corticosteroids, and also on the safety and tolerability of the steroid therapy. So critical appraisal, it was a retrospective study with small sample size, and it mainly included the European population. The details regarding the subgroup of patients who received the steroids is not given. That is, if the patients had features of inflammation like MR vessel wall showing an enhancement or a positive serology, those subgroup patients, whether they have benefited in a, that is not analyzed. Should Actually, they did not mention about the vessel wall imaging. That data is not available. And also because of the financial issue, they are not that they have told vessel wall imaging. Then, so the study has provided a unique opportunity to examine changes in FCA management from 2010 up to 2022. And after this modest evidence from the study by Stenlin et al., pediatric stock centers began using IV corticosteroids to treat FCA, but with considerable variability in practice. And the observation of similar outcomes, despite greater FCA severity in the steroid-treated patients, suggests a potential benefit. And then we have the ongoing PASTA and the FOCUS trial may provide rigorous data about the efficacy, timing, and safety of the intervention. Oh, that they're not mentioned. In VIPS 2, it was 349. 1 year. up to 479. In VAPS one, that data they told 73% of the patient had profession by FCAS when they.
Make the diagnosis. Cannot be these are very right. Most of the decision to treat will be made from this kind of with a lot of
We are winding up the section. Thank you.